Well, hello and welcome to the 27th Degree with Chris and Nancy, being broadcast from the BioSkills of Northeast Studio in Fall River, Massachusetts. Today, we'll be discussing tardive dyskinesia with Dr. Jennifer Mondillo. Before we begin our conversation, I'd like to thank our sponsors, Bay Coast Bank. Bay Coast Bank is just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. And Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centreville. For more information, visit their website, duncanhearing.com. As always, you can support the 27th Degree with Chris and Nancy by subscribing to us on your favorite podcast platform or on YouTube, and by following us on Facebook and Instagram. Also, please remember to leave a review. So, first of all, can you tell us a little bit about yourself so the listening audience and viewing audience can know a bit about your background before we get into tardive dyskinesia?
Sure. So my name is Jen Mondillo. I am an adult nurse practitioner by trade. I see patients in multiple different realms. I do long-term care visits. I do some psych. I do assisted livings. I have worked in multiple areas of the healthcare arena throughout my career. And through that, in addition, which is my full-time world, I teach at Villanova University. Mm-hmm. I run our adult geriatric nurse practitioner track, where from soup to nuts, we accept, we admit, we help place them in clinical sites, we find appropriate clinical sites for them, and we teach them all of the content in their last clinical year, as well as an advanced physical assessment course. So it's kind of nice to be able to bring my clinical world, which is real life patient experience, every day into the classroom, because I might teach on a Wednesday and Thursday I'll be seeing patients. So it's really a nice mix. I always say I have the best of both worlds. Throughout my career, I had taken different paths, and you'll see along the way I did an MBA in health administration, mm-hmm. which I found one of my most fascinating degrees because it taught me the business side to healthcare that many of us in the clinical world struggled with. So it was kind of fascinating. And then from there, I went on for a PhD in nursing education to kind of, as my husband says, put the bow on it, which kind of ties all of my degrees together and gives that kind of overall rounded experience to my students.
Wow, that's a lot of education, a lot of experience.
It was all very unintentional, I will say that. It was not, I did not set out to plan the multiple degrees, and I say this to two children who are now in college, that it all occurred along the way in my career with people I had met who, in one profession wanted to do an MBA and said, do you want to do it along with me? And, you get to the end goal, and it puts you in the places you are in this world.
Yeah.
So tardive dyskinesia it's also a topic I'm very, very much interested in also. And I would bet that many of the people who are watching this podcast really don't have much of a sense of what this condition is. So maybe we can start really at the ground level and talk a little bit about what tardive dyskinesia, or TD, is.
Sure. So again, it's a passion of mine as well, and I've seen it so often in my career. And about 4 years ago, I had gone to a dinner and was picking up some additional education, and had learned at that point in time how underdiagnosed this mm-hmm. disease was. And I had so many light bulbs that went off in my head as a provider of the education that needs to be out there. And we were coming out of a crazy time with COVID, so there really wasn't much education that was out there. And the more I educated myself about it, the more I had a passion to continue this education going forward. And tardive dyskinesia, we've probably all seen the commercials about it now, but tardive basically means delayed, and dyskinesia means an abnormal movement. So together, tardive dyskinesia is defined as uncontrolled movement disorders that can occur after taking certain medications for mental health conditions. And these medications are called dopamine blocking agents, or antipsychotic medications that many patients take. They in turn can have some side effect, which would be these abnormal movements. They get seen as twisting, jerking, sometimes dance-like movements, more on the severe end. But it can occur in any muscle of the body, which fascinated me because I remember learning it early on in my career. I always assumed it was just face and eyes and jaw
Right.
and the mouth. And as I began to pick up more and more education, I've realized how many muscles of the body tardive dyskinesia can impact.
Right, and it's one of those things that we have probably all seen at some point, but I think many out there really, before the commercials and the education that started to flow out through public media, I think a lot of people really didn't know what it was. They just associated these abnormal movements with the chronically mentally ill, but not really understanding what it was all about. And there's some other medications other than antipsychotics that can do it, but to a much lesser degree. But it might be worthwhile just mentioning that too.
Correct. So there are some other medications that are out there. One, for example, might be a Reglan, and these medications were given early on where these movements, as a side effect, came out, and they're usually given for like nausea or people who have difficulties with GI systems that can many times cause these additional movements to occur. We're very cautious with tardive dyskinesia and those other medications. So they're not given as regularly as we do see them now in the antipsychotics.
Right.
And I believe that we're seeing more of a rise in tardive dyskinesia with the antipsychotics, even post-COVID, because I think with the telehealth world, the stigma has kind of lifted a little bit with patients who have some of these conditions of major depressive disorder or schizophrenia or bipolar who are afraid to come in for treatments.
Right.
Now are getting these treatments, and we're seeing this more come to the surface. So I think we're seeing more of the antipsychotics being used, which in turn, for years we just kind of taught it and even treated it as if it was just a side effect to a medication. And now there are things that can help it.
Right.
Jen, you mentioned that it's like undiagnosed a lot. How come?
So I truly believe people believe that this is just what happens when you take a medication. Almost like I use my scenario when I do a lot of this education in saying that when you have chemotherapy, many patients know they're going to become nauseous.
Right.
And many times providers will give a medication for the nausea. This is very similar, except for the fact of for years, we didn't have anything in our toolkit to help treat tardive dyskinesia. So the toolkit was very limited. And now that there are these DRBAs, or these dopamine receptor blocking agents out there, we now have a tool that just because you have a side effect to a medication, I now can help that. So I think it's so underdiagnosed because people just thought of it as, well, it's a risk benefit to the medication I'm taking. This is going to be my risk, but I need the benefit of taking the medication. And I think the education piece really hasn't skyrocketed yet with the amount of people who can utilize these medications. I say it all the time. It's like a sleeping giant that we just haven't really gotten to yet because, in the pharmaceutical world, this DRBAs, or dopamine receptor blocking agents, are still in its infancy. I believe they're about 7-8 years old now. And 3 of those years were COVID. So I say we kind of, mummy walked through the COVID years and didn't really bring out new drugs and learn new things. And it's interesting. I do believe we're going to see more people treated in the future.
I think so. I think it's underdiagnosed. One of my thoughts is too, because for so many years, from let's say around 1957, when we first started to see this condition, to about 2017, when treatment came forward, there was really nothing you could do for it.
No.
There was no adequate treatment. So why even bother diagnosing something that you can't treat? Now we have treatment for it that's quite effective, so it makes sense to diagnose it. But there are even physicians out there who don't understand there's adequate treatment available. And we'll talk more about that, I'm sure, as we go on. But you're right. It's only been, if you think about it now, right, 8 years that we've had treatment for this condition that's been present since the late 1950s.
Right.
Yeah.
Yes, that's in its infancies. And I always say, when I learned about tardive dyskinesia, it was a one line in my pharmacology class
Right.
when I learned about antipsychotics, and this is just what it was.
Yeah.
And then I think when I began to become more educated on this myself, I think that's where my passion came in, because I've
Mm-hmm.
even changed how I teach um, my neurological conditions and my psych courses that I teach at Villanova. I now incorporate tardive dyskinesia as a big component
Sure.
because it's so prominent. And I think the more education we can get out there, the better our patient outcomes will
Right.
be and the better their quality of life.
Yep, prominent, underdiagnosed, and has a tremendous effect on quality of life. And I think one of the important points you made earlier was that we are seeing more of these drugs being used for a variety of reasons. I mean, in the past, it was really the more severely chronically mentally ill that these drugs were used for schizophrenics, bipolar. But now, you see it as an add-on for major depression and other diagnoses that, years ago these drugs would not be used for. And sometimes there's inappropriate use of these drugs too, like sleep disorders and that, but that's a whole other issue.
Right.
So,
Very true.
yeah.
There's always the off-label world, but
Right.
it
So
is it is becoming more prominent.
it is. So why does it occur though? And we talked a little bit about the drugs that are involved, but what happens in the brain to produce this condition?
So what happens is, as certain mental health medications are utilized for a longer period of time, it can cause changes in the brain that are responsible for muscle movement. So as the brain begins to adapt to taking these medications and the changes in that brain occur, the disruption results in these tardive dyskinesia movements. So over time, usually patients will say, well, I just started taking it. How soon will I see this potential risk? There's no way to know.
Right.
Some patients may not see it at all. Some may see it within the first 6 to 8 weeks. It really depends upon the brain receptors and how their own individual brain responds to that medication. And that's where that disruption comes in, and then you get these abnormal movements.
And we have some risk factors that are patient-centered that we'll talk about, and there are some that are drug-centered also. But what I always think about is, and tell me if you agree with this, you have a chemical, a dopamine receptor blocking agent. It blocks these receptors in the brain, and in response to that, the body tries to respond in a way to counter that. So there's what we call upregulation, or an increased amount of these receptors that are produced, and that often is a permanent change in the brain and how it functions. And with the increased receptor numbers and function, you end up with these abnormal movements. So that's how I think about it, because dopamine is associated with movement, and now we have more receptors available for the dopamine that's present. So.
Right. And the higher the risk, the more potential movements people can occur. So those that are over 55
Right.
or postmenopausal, those who may have history of substance abuse or any mood disorders. So it's always important to talk to your provider, your healthcare provider, to see what your risk levels are.
Right.
Because I'm a firm believer in that little bit of education will help move it forward for them to making their best decisions.
Absolutely. I mean, it's like everything. There has to be some shared decision making. It's a risk-benefit analysis, but what we want to do as providers is make sure that we at least discuss it, because I think in some instances in the past it was just never discussed. It was an accepted potential side effect, and patients unfortunately found out about it when they developed the condition, which can be lifelong.
Right.
Thankfully, we have treatment now, though.
Yes, and that's the other piece to it is it's not a condition that people say, well, if I stop taking the medication, will it go away?
Right.
I wish. You can stop taking the medication and still see these side effects.
Right.
Forever?
Forever.
And in fact,
obviously we now have treatment for it, but
right.
The side effects don't change. The chemical makeup in the brain changes with the dopamine. So what happens over time is, even if they stop taking the medications that are causing these side effects, the antipsychotics, these side effects don't go away.
fact,
which is why
sometimes it
yeah,
gets
treatment
worse. Sometimes it
is
unmasks
bad.
it. So, you have these chemicals that are blocking dopamine. Now you have a bunch of extra receptors, right? Now you take away the dopamine receptor blocking agent, and they have more dopamine function. And think about dopamine as being involved with movement. So now they have more uncontrolled movements.
Oh, jeez.
So, and we don't want people to take away their meds that they're on for their psychiatric condition anyway, because that can
No.
lead to other problems. So,
Well, and many times in today's world, and I always say to my students as well, my patients, you have to put yourself in their shoes.
right,
They want to take the least amount of medications on the least amount of times per day. So if they see a side effect to something, they think, well, I'm just not going to take it anymore.
right,
But that's where that education comes in. We
right,
really need to educate them that your schizophrenia or your major depressive disorder is not going away, but I have something that can help you.
right,
Do you
right.
see it equally distributed between men and women?
Right now, yes. The distribution is fairly equal over a certain age. And again, it depends upon the antipsychotic they're on. Some of the older medications have a higher risk of developing TD. So, our elderly population who are on the Haldols earlier in life, who now we have newer versions of a lot of antipsychotics that are out there, which have a lower risk for both men and women alike. But it is fairly evenly diagnosed. It really depends upon the patient population you see and who is getting treatment, because we have a lot of undiagnosed psychiatric conditions out there
Right.
today.
Right.
What are some of the older meds that carry a higher risk of tardive dyskinesia?
Great question. One of the biggest ones, and I always bring this up, is Haldol.
Mm-hmm.
There's approximately a 30% chance of developing TD for those that were on Haldol. And again, back in the early days of when these conditions came about, it's all we had in our toolkit.
Right.
So that's why we're seeing those 55 and over have a higher chance for tardive dyskinesia, because they were on some of these older medications. And you have your first or second generation antipsychotics, as we call them, and those that were on these first generations have a higher risk. They say that it affects approximately 800,000 adults in the US and those living with TD, and 60% are undiagnosed today.
Yeah, that's amazing. It's really a condition that there's so many people that could be helped if they were just diagnosed. But
Jennifer,
those older drugs, though, they are associated to a greater extent because they bound to that dopamine receptor more strongly, right? And that's probably a
Right.
point that's useful to get out there. The newer drugs, which have less risk of tardive dyskinesia based on how they function with the receptor, aren't devoid of risk either. And that's important
Yeah.
for people to know also. But let's talk about the risk with the newer drugs and maybe some examples of some of the newer drugs that we see being used now more
Sure.
than those first generation antipsychotics.
Right, and that's the bigger piece, because those first generations, which are older medications, they're very potent, and the dopamine receptor in it is very potent. With the newer ones, just like with everything in life, medications and pharmacology progresses. So a lot of our newer versions of antipsychotics that roll off people's tongues today are Abilify, Rexulti, Latuda, Zyprexa, Seroquel. A lot of the ones we see commercials for. I have a lot of patients that come in and they say, I saw a commercial for this. I'm like, oh boy. Which is great because they're getting the education, but it's up to us to kind of take that piece forward. And that a lot of these newer versions of antipsychotics still have a risk. So if people are on any of them, they can still develop tardive dyskinesia, but their risk is lower. But it's still approximately a 7% risk. So if you have 14 patients on the medication, 1 in every 14 can develop TD.
Mm-hmm. And then there's all those patients who maybe were on Haldol years ago, and now they're on a second generation, and they're going to have a risk somewhat in the center, correct?
They do. The risk kind of evens out a little bit if they're on Haldol earlier in life, and now we moved them on to one of the newer medications that are not as potent, but still as effective. That risk level kind of balances between the high level of the first generations and the newer antipsychotics that are out there. So they're going to fall in the mid, I want to say to the mid 30 to 40% range.
Jennifer, if I'm like taking some of these medications and I'm like, okay, a year's gone by, I've been on them, I haven't come down with any symptoms of tardive dyskinesia, am I like scot-free, or am I like,
That's a great question. No, unfortunately. And I can give you an example of a woman who I had the pleasure of having dinner with who lives with tardive dyskinesia. And she was diagnosed back in her late teens. She was in college, so early 20s. And she was an engineer. And she came out of college, played softball in college, and worked for quite some time. Started on the earlier generations of medications and then switched over to one of the newer medications and started to notice that she had these twitching movements with her mouth. She didn't really notice it. A colleague of her noticed it, and then when her partner had said something to her, and she just blew it off. And it ended up being a commercial that they saw that kind of really put the pieces together. But she went for almost 16 years without any movements. And like she said to me, I don't know if I had them because no one ever pointed it out.
Right. That's always an intriguing part to this, that sometimes it's others that notice the condition first, and I've noticed that also.
Yeah, I say many times to my patients, even my students, that becomes their normal. So they just live with it.
Correct.
Patients that work with a cane, that becomes their normal. Patients that have a twitch or a movement disorder, or even our Parkinson's patients, that becomes their normal. So when they come in to see us in the office, they don't tell us. It's up to us to do our health assessment portion to the visualization of seeing, do we notice something?
Now, this patient that you were just discussing, they were on the antipsychotic all along, and then they developed it many, many years later, or were they off it and then developed it many years later?
No, they were on it for a really long time.
Okay.
Started on a first generation. As she got older and more astute to the medications that were out there, she switched over to the newer second generations that are out there. And it wasn't until someone else pointed out her mouth movements.
Okay.
And she said she was able to hide them for some time, which gave me a whole new impression to the masks in COVID world. She said when COVID ended and she took off her mask, she was very conscious about it.
Sure.
Jennifer, is it, when you have these delayed movements, is it like constant, or are some days you good, then other days you're not good?
They're usually a constant movement, and that's the piece to it. It can be exacerbated. So, for example, if you could have patients do what we call activation maneuvers, where like if you do finger to thumb, or if they're cognitively not able to do this type of assessment, we could ask them to do like a behavioral assessment of saying the months of the year backwards for me. And when patients start to do other things, you'll start to see the movements increase, because then that's telling me the dopamine is firing in different ways. So there's different ways to watch it happen. Some patients are very good at masking it. You'll see it sometimes in their hands, so they'll sit on their hands, or they'll speak slower, or they'll chew gum. So there's a way to hide some of these movements, but they usually just are a constant movement for them.
And it must be exhausting to try to hide it also, I'm guessing. And exhausting if you have these really significant movements that you're having all day.
Correct. And that's the hard time. I mean, it's, if you're constantly moving, and I always say this, it's not just the tardive dyskinesia. Yes, that is our primary reason for treatment. But you do have patients that are losing weight. You have people that can't swallow, their diaphragm, they may have GERD. There's so many other components that tardive dyskinesia can cause.
Falls.
Right. We don't even think about it until, the more we educate about it.
And the psychosocial impact can't be underestimated, too. You have many people who have TD have suffered and struggled with mental illness their entire lives, and now you throw into the mix a condition which makes them self-conscious, makes them isolate, and that has its own effects, unfortunately, on their mental health and their quality of life. Yeah.
And I say today, it's such a hard world we live in with social media. People are quick to take out their phones. If they see somebody acting strange,
Sure.
they'll videotape them and send it to 10 friends. So I really believe people try and hide it more than we know, which is why I
Hmm.
truly believe it's so underdiagnosed. It's a cruel world with
Sure.
the accessibility to phones today, and people want to stay socially isolated. So you run that risk if they don't want to get on the SEPTA bus, they don't want to get on public
Right.
transportation, and they don't want to go to the mall. So they socially exclude themselves, and you run into other risks.
It's so true.
Primacare is Southeastern New England's trusted leader in medical care. With offices in Fall River and surrounding communities, we're dedicated to your well-being. Our carefully selected team of more than 150 providers offers world-class primary and specialty medical care. Primacare doctors are supported by a skilled staff trained to deliver comprehensive radiology, imaging, and testing services. Primacare is large enough to take care of all your medical needs, but small enough to care for you personally. Primacare is by your side.
So, right, if you go on to public transportation and there's that one person who has suffered, unfortunately, from chronic mental illness and now has severe tardive dyskinesia, you'll notice that the bus can be full, but no one will sit next to that person. There's this fear that others have of the condition, and these folks are very isolated, unfortunately. And I see it in the nursing home sometimes that patients who have it will eat their meals in their rooms. They won't go to the dining room with others. And then once you treat the condition, they'll kind of come out of their shells and now they'll interact, and their social interactions just improve dramatically. And now you see that they're eating in the dining room rather than staying isolated in their rooms.
Chris, when you treat the conditions, and Jennifer, when the conditions are treated, do the symptoms go, like, is it 90% they go away? Is it like, do they go away?
Well, it varies person to person, but there's an actual incredible rate of total remission with this condition with the treatments that we have. So, and I'm sure that Jennifer will talk a bit about that too. So we have real great success with treating this now, where, before 2017, we had really nothing.
It's a game changer.
Yeah, it really is a game changer. That's part
Right.
of the reason we wanted to talk about this condition. One, because it has such a great impact, it's so underdiagnosed, but we actually have treatment for it.
Right, and that's the hardest part. Is for years there was no treatment, so patients would go in the rooms, and I see it in the nursing homes as well. I'm actually one of the assisted livings I was in earlier today. It was so easy to point out, and I said to the staff, I said, I haven't seen her come down to the dining room in the past month. And they're like, oh, she's just kind of keeping to herself. And when I went up to talk to her, it was the first thing I noticed. And went downstairs, and I was educating some of the staff, and they didn't even know that that was the potential. They just thought she was getting older. She didn't want to come down.
Right.
Here, first thing she said to me when I said to her, do you notice you have movements? And she started crying. And she's like, everybody at the table stares at me. And at this point in my life, I don't need it. I'd
Wow.
rather just be alone. And I was like, wow. So 60% of the Americans that have TD have not been diagnosed or treated. So if you look at that, she's one of that 60%.
Right.
How many of them don't even know they have it, or don't know who to tell because the staff don't recognize it?
Right. So how do you make the diagnosis?
So there really is no lab work. There is no specific way to just, come out and say this, you have tardive dyskinesia. We utilize what is called a Ames scale, which gives us a score. And in that scoring, we can see the volume of the movement, and we have them do different tests and ask through different questions in that Ames scale. We rate it at the bottom of a score that gives us the severity of tardive dyskinesia for the patient. And that's really all. A lot of it is a health history. A lot of it is your physical exam and just assessing them as they're talking, as they're moving. There really is no lab work, no CAT scans, nothing we can do to diagnose it. And a lot of it comes down to getting a really, really great thorough history of the patient.
Right.
And you can treat, the treatment will be covered even if they have mild tardive dyskinesia, which is great.
Right. Right, and I've had patients who have mild tardive dyskinesia that are really affected by it. And one story I remember was a patient who just had a little bit of toe movement, and she was one of my primary care patients, but she was really self-conscious because she couldn't wear her sandals in the summer. So, she had heard about the drug and she wanted to try it. And, she was really thrilled that there was a treatment for that could allow her to be less self-conscious.
So it's funny you went into the sandals because one of my passions of getting this information out there to as many people as I can is because I say I started out in nursing. I was a nursing assistant, and I worked my way all the way up through nursing assistant, unit manager's director of nursing, all the way through to where I am today. And I love educating or getting this information to the frontline staff. Many times, a lot of providers will say to me, but they don't know how to diagnose it. I said, I don't need them to diagnose it. I need them to be able to recognize it. And if you see something, say something.
Right.
And many of the aides that I have gone out or educated around will say that to me. And I always say, look, my husband is completely non-medical. And we go to Florida quite often. And he always has asked me, what do you go and educate about? And why are you so passionate about TD? And he's like, I don't even know what it is. And I said, well, and I explained to him what looks like piano playing fingers and toes. So patients will have involuntary movements in flip-flops or sandals where their toes are constantly moving, and they can't stop them. So then in turn, they become very conscious and they don't want to wear them. Well, if you've ever been in the Florida airports, everybody's in sandals and flip-flops.
Right.
So now my husband, who is completely non-medical, will say to me, I think that woman over there has what you teach about. And I said, well, not quite sure what you want me to do with the information.
Right.
But you're probably right. And he goes, I don't know. I just can tell that that's not normal. And it's key to understand that because I don't think tardive dyskinesia just needs to be taught provider to provider. It can be taught to everyone about this is what it is. You might not know what it is, but tell us and we can help you. And they're the pieces where the education really comes into play because the frontline staff are really ones who see it all the time.
Right. It's true. They do. And you don't need to be a doctor to diagnose it, quite honestly.
No.
This is something that can be recognized, and maybe not diagnosed, but recognized in facilities, nursing homes, dietary staff, rehab staff, activities staff. Certainly, you mentioned the nurse assistants who probably spend more time with the patients than most. And then, of course, our nursing staff, docs, administrators, anyone can really recognize this and bring it forward.
Right. And even, with the example of the patient I gave earlier, it was a colleague at work. And it was, then her partner had said something when she saw the commercial. So sometimes it's just pointing out the obvious that people are afraid to talk about it because that stigma's still there. And when you kind of open that door, it's a bit of relief for the patient because they don't know if there's treatment measures out there, but there are.
Right. And there are now. Right. And we've mentioned how important it is to diagnose it, not only because of the kind of psychosocial effects on the condition, but all the other things that go along with it potentially: falls, weight loss, choking, et cetera. I mean, every muscle in the body can be affected, so you can think that there's quite a lot of fallout from that. But let's talk a little bit about the treatment, because this is exciting because we never had treatment years ago, and now we do. So maybe you can tell us a little bit about how you treat this and how these medications work, because I think it's really fascinating how we think they work.
Right. It is really fascinating. So the first treatment for TD was actually approved by the U.S. Food and Drug Administration in 2017. So like I said to you earlier, it's, to me, for some of the medications I've used throughout my career, that's still in its infancy phases.
For sure, absolutely.
I know, 8 years is still fairly new. There's people who don't even know of these medication names. And the class is called a VMAT2 inhibitor, which the goal of these medications is to help some of the brain changes that we mentioned beforehand to reduce the severity of TD movements. And many times patients will even achieve remission, which is fascinating. So there now is this new treatment after 70 years because, like you had mentioned earlier, the first case back in 1957, which hopefully I mean, I can say we had talked about age earlier. I was not born. So if you go back for before my lifetime,
Right.
uh,
You remember that, Nancy?
that's a really long time
Right.
to have a diagnosis without treatment.
It is a long time. And it's also really, it's fascinating to think about. This condition didn't exist before that time because we didn't have antipsychotics before, 1952 or so, or 51? I can't remember the exact year. So, those came out in the early 50s, and then we started to see this condition in 57. So, it's really, unfortunately, a condition that I guess we've created, but these drugs are necessary, these antipsychotics. We don't want to have people go off their meds, of course, but thank God now we actually have a treatment for it.
Right. And many times, I think, I mean, I had light bulbs go off for myself even 4 years ago when I realized that there are treatments out there for these movement disorders that can affect my patients that had swallowing issues. I just automatically jumped to potential aspiration risk. And now it gives me another road or another light bulb that might go off for a potential differential diagnosis
Right.
that I never really put two and two together before this education kind of really came to the forefront, which is really fascinating.
It is. And I mean, I don't know if we want to get into the details of this because it gets really interesting and, I mean, kind of involved, but I just love the way that we think. We don't know for certain 100%, but the way that probably these drugs work, I think is really fascinating too. So, and I'll just throw this out briefly. So, what we're trying to do is we're trying to decrease available dopamine to these dopamine receptors. And remember, there's now more dopamine receptors because we've been blocking the receptors that are available, and the body's kind of what we call upregulated. So there's this whole recycling process of dopamine. Once it kind of interacts with this receptor, it goes back to the presynaptic neuron. It's interacting on the postsynaptic neuron, and then it's recycled and goes back out to that receptor again. So what we're doing with these VMAT2 inhibitors is we're basically reducing the ability of recycling, I guess I would say, the dopamine, which is really it's just fascinating the way it works. It's just, I just find it so interesting.
Me too.
And it works so well, too, for many patients.
It does, and it's a very hard mechanism of action to describe. So I'm a visual learner.
Right.
So I always say to my patients or my students that you have this dopamine and here comes this little like fidget spinner and it blocks it from firing everywhere in the brain to slow down that dopamine from allowing all these movements to occur.
Right.
And how much of that dopamine you have will depend on how well that medication works. It's fascinating that there's no real clear mechanism of action, yet it's so effective.
Yeah. Right. We only have thoughts of how it works, but we can't really prove it exactly, but it does work quite well. And a drug that can actually produce remission is rare in many conditions. I mean, if you think about it, there's so many conditions we treat: congestive heart failure, diabetes, and sometimes we get patients to a good place, but we don't use the word remission usually.
Right. And that's fascinating because that's fairly new with the research that patients have achieved that remission rates of not seeing any symptoms. Some have, when we do what we call the Ames assessment, they will score a 0 after they've been at the highest level. So it's fascinating to see how impactful it can be today.
And that can be the difference between someone not feeling that social isolation, someone now being able to button their shirt, being able to feed themselves where before they might not be able to. I mean, these are remarkable things that can improve.
Right. And that's the piece that we were missing all these years because, like I say to so many patients and students, are like, why didn't I know about this before? And I said, that's the fascinating world of medicine. As things develop and come out and the education comes out and the research, there's going to be ways to help things that we may not have been able to help in the past.
Right.
Jennifer, are you finding that more doctors are explaining tardive dyskinesia to the patients when the antipsychotics are ordered?
So I still think we have a little bit of a gap. Sometimes it might be a generational gap. I think some of the newer providers that are out there are efficiently able to explain it in regards to the medication, but it's really specific upon the provider as well as how much information they have, which I think the importance in the education is key, which is why I enjoy doing these so much. Is I think the more education we can get out there, the more beneficial it is for providers. And again,
Right.
it's new. It's a new drug, so we need education. Otherwise, there's no other way we can know about them.
It's kind of an observation I have too is sometimes, like when I go pick up a new medication at one of the pharmacies I visit, and the usual
Right.
pickup line for
Pickup line,
pharmacies.
yeah.
Pickup line is, hey, do you have any questions about this medication? And I'm
Right.
always like, nah, but that's our safety net, right?
Right.
So maybe we should default to yes. Just tell me a little bit.
Well, and part of it is how many people at the pharmacy counter want to talk about their diagnosis.
Very
So
true.
it's
True,
really
true.
difficult. I mean, I have a son that has a peanut allergy, and I picked up his EpiPen today before he leaves for college. And they're like, "Do you have any questions?" And I laugh at that all the time because I think, if I did, would I ask you right here?
Right. Right.
And it's not their fault. It's just the way our health, like the way the pharmacies are set up.
Right.
I mean, there is some new dynamics coming out. I was just at a pharmacy, I guess about a week ago, and usually you walk up and they ask for your name and your date of birth, and you're shouting it out to the world around you.
Right.
They had a kiosk, and the kiosk at the bottom of it asked, "Do you have any additional questions you would like for your pharmacist?"
That's nice.
That's nice.
Nice.
And I thought that's kind of fascinating because we might get some information out from these patients who are afraid to ask.
Right.
Right, and we need to have our pharmacists to be able to answer these questions for our patients, because if we're getting our information off the internet, it's not necessarily always the best. I find a lot of patients are fearful to take meds and sometimes don't take their medication because if they look up the side effect profile, even if I've told them what the side effect profile is, they get a list, but they don't know what's common, what's not common, and that's a
true,
real
too.
problem. So, and we don't
And
want,
I think
we don't want patients not to take medications that are going to benefit them.
right, and it's hard today because they have so much accessibility to
Right, right.
online resources that are good and bad. I said this last week at work. For the first time in my career, I had a patient come in and say, "Well, ChatGPT told me." I was like,
Yeah.
"Oh, I'm competing with artificial intelligence." And I
Right.
said, "Well, what did he say?" But again, that's where they're going to get their information. So I always kind of turn them back to, check your resources. If you find
Right.
resources, come to me. And the education is the biggest piece. I tell all my students and all my patients, your pharmacist should be your second best friend to your provider.
Absolutely, I
Nice.
agree. I think they're, sometimes, especially as pharmacies have become more busy, and pharmacists don't have the opportunity to interact as pharmacists did in the past.
Right.
They're not valued as they need to be valued.
Yeah.
I mean,
But
it's too bad. It really is. Our healthcare system has made it very difficult to be a pharmacist, I'm sure. And I have a lot of pharmacist colleagues, and they tell me it's very difficult these days. But they are there, and they're a wealth of knowledge, and they're there to help out. But I think that as far as the education goes, I mean, part of that is, of course, educating patients, but we still have some work to do to educate physicians too, it seems. I mean, I think there's
I
a lot of
agree.
physicians who, and providers, I'm not going to just blame physicians, it's practitioners in general who, one, maybe don't know what tardive dyskinesia is, or if they do, they don't recognize the importance of it. Or two, don't know that there's actually even a treatment that's incredibly effective that can lead to remission.
Right. And I think many times the struggle we all have is patients don't want another medication. And some providers believe, like, I gave you this medication to help your greatest risk, which might be, schizophrenia or bipolar. but now you don't want me to give you another medication to help those side effects. They just want me
Right.
to stop the first medication. And actually stopping it can make the movements worse.
Right.
So,
It can make a
it's
lot
catch-
worse. It can make a
yeah,
lot
a lot
worse.
worse. And
Right.
it's a catch-22
Right.
with a healthcare provider if they're not educated about it.
Right.
I always use my example of when you go for surgery, the anesthesiologist will usually ask you, have you ever had any reaction to anesthesia? Does it make you nauseous? My first line is always say yes, even if it doesn't, because they give you a little antiemetic in
Yeah,
your
right. Right.
Oh,
IV
that's a
that
good
makes you
tip.
feel, yes, that makes you feel better on the back end. This is very similar. If I know something can help me because I need
Right.
a medication, we have to be open as providers to know that everything we give it has a risk benefit,
Right. True.
and you
So
have to
true.
weigh the risk.
What's the message you'd like to get out to patients out there who may have, mental health issues, are on mental health drugs, and are hearing this, and they're wondering what they should do about these drugs now that they've heard that they may have a risk of developing this condition? Because I think it's important to get that out in the open. What do we want to tell them?
Right. No, absolutely. So the first thing I always make sure I say to patients is, don't be embarrassed to talk to your healthcare provider. Some of the things that they're going to come to talk to us about, we can help them with. And if there's anybody out there who's going to keep it confidential and help them, it's going to be your provider. The other piece is, don't stop taking your mental health medications
absolutely.
without consulting your doctor, because stopping it can make these movements worse. I've had many patients say, well, I tried to cut it in half,
Right.
thinking my movements will go away. And I explain to them, again, it's an education line, that cutting them in half or stopping them, you may exacerbate these movements
Right.
and not making them better, but making them worse. The other piece is, we have a lot of patients today who are out there taking herbal supplements and
Right.
a lot of these extra vitamins that are out there. There's really not a lot of evidence out there to show they can work, and they may interact with some of their other prescription meds. So they need to come and talk. Set up a time to discuss, what your concerns are.
Right.
And one of your concerns could be your movements. And whether it's social, physical, emotional, mental health, any of those conditions, if it's something that bothers you, go to your
Absolutely.
provider.
And I also get worried about people stopping their meds because then their mental health issue may worsen also, and that's also a real concern. So if you're stable on a drug, the last thing you want to do is stop it because of a potential side effect, particularly if we can treat that condition now so effectively.
Right. And I think sometimes it becomes their norm. They've been on some of these medications for so long, and then now they start to develop these movements, and they hear a little bit, somebody mentions it to them, or they hear about a medication that's out there that can help them, and they're like, oh, I'm just going to slow down taking my medication.
Right.
And now one rises and the other gets worse
Sure.
at the same time. So the biggest piece is, do not be embarrassed to talk to your healthcare
Absolutely.
provider. There are
That's
things
what
we can do.
we're here for. What are some other resources for patients other than speaking to their practitioner?
Sure. So there's the Depression and Bipolar Support Alliance that's out there, which is very, very helpful with education. There's resources out there for them to use. The Mental Health America and the National Alliance on Mental Illness is also out there as well. There are support groups people can reach out to. And again, I would say start at home. Start with your provider. Start with a trusted individual who can direct you to the right path.
Right.
And this is where our world of social media and the internet can help, because these patient resources are there for them to have that first step before they come into us if they're afraid to talk to us about it.
Right. All right. One message you want to leave the audience with before we close.
I think my one message is, the more we can educate and understand about tardive dyskinesia, the better our patient outcomes will be. From a quality of life standpoint, from a medical standpoint, I think it's so underdiagnosed at the moment that we're only going to see it rise.
Absolutely.
And the more we can help our patients, the better our outcomes are.
That's great. Well, this was a really fascinating discussion.
I think
I
so
really
as
loved
well.
it.
Thank you so much.
You obviously
Great.
have a passion for it. I do too. And it's just such an interesting topic. And it's just something we can really help patients and impact on them in a positive fashion.
It is.
by
And I
getting the
love
word
to
out.
see the success stories. I love it.
And there's
It's
a
my
lot of
favorite.
them with this condition. So, well, thank you everyone for listening to our show. If you'd like to become a sponsor, contact us at 617-775-3737. Special thanks to Ron Gamache for our intro music, Primacare, your trusted medical providers in southeastern New England, the BioSkills of Northeast for producing our show, and available to produce your show by calling 774-301-8811. Bay Coast Bank, just right for all of your financial needs. Visit baycoast.bank or call 508-678-7641 to learn more. Duncan Hearing Healthcare you can trust, with sites in Fall River, Dartmouth, Falmouth, and Centerville. For more information, visit their website, duncanhearing.com. And of course, thank you to Dr. Jennifer Mondillo for being such an expert on this and taking your time to discuss this and having such a passion for such an important condition. Thank you again.
Oh, thank you for having me. I enjoyed it. Thank you.
Great.